Good afternoon, ladies and gentlemen. I'm Serena Collado, Director of Community Health at Robert Wood Johnson University Hospital Somerset's Community Health Department. Welcome today to today's webinar, Mouthing Off on Oral Cancer, presented in collaboration with Friends Health Connection and in conjunction with Oral Cancer Awareness Month. Each year, about 52,000 new cases of oral cancer are diagnosed. During today's webinar, we will learn more about oral cancer, including symptoms, risk factor, diagnosis, and treatment options. We are pleased to be joined today by our special guest, Dr. Mena Abraham, an otolaryngologist with Robert Wood Johnson University Hospital, Somerset. We will begin our webinar with about 20 minutes of a moderated discussion with our physician, and then we will open it up to questions from our audience. If you have a question for Dr. Abraham, please enter the question in the question and answer section. So thank you so much for joining us, Dr. Abraham. We really appreciate it. So if you could start, maybe we could start off by having you tell the audience a little bit about yourself.
Thank you for having me. It's a pleasure to be with you today, Serena. So my name is Dr. Mena Abraham. I'm an otolaryngologist, also known as an ENT physician or a head and neck surgeon. I grew up in Brooklyn, New York, and I finished my medical school training at the New York College of Osteopathic Medicine in Long Island, New York. Then I headed to a 5-year residency in Philadelphia and settled back in Bridgewater, where I've been here for the past 5 years, and I'm enjoying it so far.
Great. Well, again, thank you so much for joining. So with oral cancer, we know that this, affects our mouths. And so when we say mouth, can you explain what areas that includes?
Sure. So head and neck cancers in general are divided into several categories or subsites. Oral cavity cancers happen to be the most common type of head and neck cancer. It makes up about 38% of all head and neck cancers that we see. When we talk about the oral cavity, we're specifically talking about the lips, the alveolar ridges, which is the bone that anchors the teeth, the hard palate, the tongue, the floor of the mouth, and the buccal mucosa, which is the inside of your cheeks. Everything past that is a different subsite of head and neck region that has its own categories of classifications for cancers.
Okay, well, thank you for explaining that. So now oral cancer, who is at risk for it?
From an age standpoint, we see that the average patient age for presenting with an oral cavity cancer is around the age of 60 years old. 95% of all cases happen in people or patients over the age of 40. And we can talk in specific about the risk factors and who exactly is more at risk for oral cavity cancers.
Okay, so did you want to talk more about that? Did you want to elaborate? Sure. Please feel free.
Absolutely. So the most or the greatest two factors for being predisposed to oral cavity cancer is smoking and drinking alcohol. And really the effects are multiplied the longer or the more you smoke, or the longer or more duration of years you consume alcohol. So for example, in a person who's a light smoker who smokes less than 10 cigarettes per day, they're at a 1.5-fold increase for developing an oral cavity cancer. Whereas you can see that a person who smokes over 30 cigarettes per day, who's considered a heavy smoker, their risk really increases to almost 4-fold. People who smoke and drink together almost have the two risk factors have a synergistic effect, where they have over a 40% or 40-fold increase in developing head and neck cancer versus somebody who only smokes or only consumes alcohol on a daily basis.
Yeah, I was just about to ask you, and thank you for mentioning that, because I was just about to say, wouldn't your risks go up the more risk factors you have? Your age range, whether you're a smoker, whether you're a drinker. And so thank you. You answered my question before I even got an opportunity to ask you.
Yeah, just to elaborate on that, a very common question I get from my patients is, why should I quit now? And it's really important to know that people who quit actually decrease their risk of developing oral cavity cancer the more years that pass from the time that they quit. So for example, somebody who has quit smoking for 9 years decreases their initial risk by 50%. And the more years that go on, the less their risk of developing oral cavity cancer or head and neck cancer in general decreases over time.
Yeah, and thank you for explaining that. Now, we know, okay, these are things that actually are risks of getting it, but what actually causes oral cancer?
So these risks, that include cigarette smoking and alcohol consumption, basically cause gene mutations in the lining of the oral cavity and other head and neck cancers that involve the oropharynx, the larynx, or the voice box, and even the esophagus. And these gene mutations basically turn off cellular replication triggers that basically cause these tumors to grow rapidly. And that's essentially what happens in most of these elements that make you predisposed to developing a head and neck cancer.
Okay, so in other words, and just to clarify, so part of it is genetics and part of it is kind of like your lifestyle behavioral choices. Would that be an accurate statement between drinking and smoking?
I would say probably environmental or behavioral risk factors more than genetics. There is not a whole lot of research that links the most common types of head and neck cancers to something that runs in the family, for example. So it's definitely environmental factors more than genetics.
Okay. Thank you for clarifying that. So is there a link between oral cancer and mouthwash with a high alcohol content?
Yeah, that's a very popular question. And the Cancer Institute ran a study that basically confirmed that people who use mouthwash that contains over 25% alcohol do have a higher chance of developing oral cavity cancers. And their subjects really were people who mouthwash twice a day for over 20 years. And they did see an increase or an increased risk of developing oral cavity cancer. And hence, the reason why many of the mouthwash manufacturers are now leaning more towards less alcohol content in their mouthwashes sold over the counter.
Wow. So, another question you get too is, do denture wearers have a higher risk for oral cancers?
That's an interesting question. There's not really a correlation between people who are long-term denture wearers and an increased risk for developing oral cavity cancer, but we do know that chronic irritation in the same area over and over again, oral cavity, or really in any area in the head and neck, can increase your chances. So people who have mal-fitted oral hardware or dentures, or poorly fitted ones where there's chronic irritation to the same area, especially in the hard palate region where they kind of tighten to anchor themselves around the teeth, that can certainly be implicated in developing an oral cavity cancer, especially if it's combined with a person who, for example, wears a poorly fitted mouth guard and happens to consume alcohol regularly.
So I think you kind of alluded to some of the symptoms. So how does somebody tell, whether or not they have oral cancer? What are some of the symptoms?
Unfortunately, and many times they're asymptomatic. They're basically lesions that the patient notices on their tongue, on the side of their cheeks, and they're concerned about it. And rightfully, they should be. Some of the more common symptoms when somebody actually has a presentation that's felt involves either pain at the site or bleeding. So many times what brings the patient to the office is having a lesion that was either picked up by their dentist or oral hygienist, or something that they saw and it basically grasped their attention and it brought them into the office to be evaluated.
Wow. So then what are the best methods of early detection? Of how can we detect this early?
The most common professions or professionals are able to do this efficiently are basically dentists and oral hygienists. So really maintaining a good routine of visiting your dentist for cleaning every 6 months. They're just very close to the area. They have proper lighting, and they're really able to inspect those cavities. And most dentists are very good about doing this. Anybody at home who basically, we commonly look in our mouths, and when we're brushing our teeth or brushing our tongue, we're commonly inspecting elements of our oral cavity. If there's anything that looks unusual, and has been there for a while and you have not seen it before, for example, should prompt you to see a physician for it. That's really the two means of early detection.
Wow. Okay, that's good to know. So let's talk about diagnosis. So let's say you or your dentist are in your mouth and you suspect that there is something. Then how is it actually diagnosed?
Sure. So let me preface this by saying that, for example, not every lesion in the mouth is an oral cancer. And the most commonly lesions in the mouth are not oral cancers. And what really should trigger an appointment with a head and neck surgeon or an ENT physician is really something that was either brought on, for example, like an aphthous ulcer or a painful ulcer that's not going away in a matter of 3 or 4 weeks. And when somebody comes into the office with a suspicious lesion, either based on timing, how long it has been there and has not gone away, or the way it appears, we essentially try to do a biopsy. And depending on the type of this lesion or the characteristics or how diffuse or focal it is, we can either do a brush biopsy, which basically is a rough brush that scrapes surface cells from the lesion, and we send it to pathologists and they're able to tell us if this is a cancer or not. Sometimes we have to do a deeper biopsy if we're still concerned and we're not convinced of the brush biopsy results.
And thank you again. I was just going to ask you to clarify the biopsies, and you beat me to the punch. So I appreciate that. So now, after a biopsy, let's say unfortunately it comes back and it is cancerous. So I understand there's stages of cancer. So for our audience, could you please explain what the stages of cancer are?
Sure. From a meaningful standpoint to a patient, there's generally 4 stages of head and neck or oral cavity cancers with subtypes to each stage. The most important thing to pick up from this is the fact that the earlier stages tend to be smaller or confined to one subsite of oral cavity or oropharynx or even voice box. The later stages tend to either be larger in size, which is actually the case in oral cavity cancers. Larger in size, or they invade other surrounding structures if they extend deeper into the muscle, for example, of the tongue, or if they extend into the bone that anchors the teeth. And the stages of cancer essentially evolve as you have a larger lesion, and the larger the lesion is, the more likely there to be cervical metastasis, which is basically cancer traveling into the lymph nodes of the neck. Similar to the way other cancers metastasize, head and neck cancers tend to metastasize not so much in a distant fashion, but more of traveling locally further down into the neck.
Okay, thank you for this, for that explanation. So then what and how what are the treatment options? How do you go about treating the cancer? And is there different treatments for different stages?
Absolutely. So because the oral cavity is fairly visible in terms of, or in comparison to other head and neck subsites, thankfully a lot of oral cancers are actually picked up fairly early, either by the patient, like what we said earlier, by a primary care physician or a dentist. The earlier lesions tend to be smaller lesions. So if we biopsy a lesion and there are cancer cells there, and this is a small lesion that could be resected, surgery is really the perfect treatment modality, and sometimes that's all we really need. The larger the lesion, or if surgery is not necessarily the method to achieve full resection, we have to involve other treatment modalities like chemotherapy or radiation. But the earlier cancers definitely respond, and usually respond, to just a surgical resection.
Okay. All right. Now, so survivors of oral cancer have an increased risk of developing a second form of cancer. So what types of cancers are they at higher risk for, would you say?
Sure. So there's a very interesting concept called field cancerization. What happens in this concept is basically understanding that when somebody smokes or, for example, consumes alcohol regularly, it's not just passing by the subsites of the oral cavity. It's passing by the oropharynx, it's passing by the voice box or the larynx. It's passing through either your airway, if we're talking about cigarette smoking, or through the esophagus into the stomach if we're talking about alcohol consumption. So field exposure here means that all of these subsites are exposed to the same carcinogenic effects of smoking or of consuming alcohol regularly. So essentially, you can have an increased risk for developing oropharyngeal cancer, laryngeal cancer, esophageal cancer, or gastric cancer if we're talking about drinking or consuming alcohol regularly, or if we're talking about smoking, we're also talking about lung cancers here.
Thank you. So, one of the things we hear all the time is that, some people have been putting off going to their doctor or getting regular screenings during this COVID-19 pandemic. So why is it important that they not delay medical care?
To put this into perspective, when somebody is diagnosed with an early cancer, for example, on their tongue, and it is resected, we routinely follow up with that patient over the course of at least the first year and into the next 5 years. And the first year is very, very important because we really need to make sure that there's no local recurrence. We follow up with them once a month. Essentially, that's how frequently we're checking in to make sure there is no recurrent tumors. If we're talking about early cancers, it's really important to basically diagnose early cancers and resect them because the treatment modalities are very different. We're talking about either a simple excision, either in the office or under anesthesia, where the recovery is very limited, versus a much larger cancer where the surgery can be more complicated. The recovery is prolonged, and sometimes we do need to use chemotherapy or radiation. So the earlier we treat these cancers, the simpler or the more straightforward treatment modalities we need to employ, and really the better outcome for the patient, because the higher the stage, the more likely the risk of recurrence there is. So when somebody is diagnosed with a higher stage where more than one treatment modality is used to treat the cancer, the risk of recurrence also is higher.
Yeah. So, and I know many of the providers have taken many safety precautions. And so can you explain, what are the safety precautions, like what Robert Wood Johnson University Hospital Somerset is taking during the COVID-19 pandemic to keep our patients safe?
Yeah, I think we've done a great job just walking in through the door, somebody to greet you with a new mask, temperature checks. All across our floors, we have reminders to keep 6 feet away. The room turnover hygiene measures that we've employed, the deep cleaning that we've done between each room turnover between patients is also very important. And from the surgical standpoint, the fact that we now basically check for COVID status before surgery has really given patients a lot of reassurance, and providers for that case, to ensure that we're doing elective surgery safely.
Yeah, and thank you, and hopefully, that those protocols that have been put in place can ease individuals' minds so that if they need the care, they will certainly seek it. Now, can you explain, we've talked about oral cancer, but let's talk about what are some general tips for overall good oral health?
I think that a very general statement here is really good dental hygiene, essentially because dental hygiene prompts you to be very mindful of the oral cavity, checking, basically visually inspecting the oral cavity. If there's anything that's painful or unsightly, it will prompt you to seek a healthcare provider to look at it and make sure that whatever you're seeing is not very worrisome. Routine dental checks, again, it's kind of the best thing that we have implemented in our culture, to visit a dentist every 6 months. That would really prevent any of these early lesions to go undiagnosed for a long period of time.
Okay, thank you so much. So at this time, I would like to open the webinar up to questions from our audience. So if you do have a question for Dr. Abraham, please put that in the Q&A section, and I will pick that up and ask the doctor your question. So I'm just going to give everybody a question. I want to just quickly elaborate on the last question, why we give individuals some time to input their questions. So can you maybe talk about, you talked about good oral hygiene. So can you explain maybe what the role of brushing plays in terms of not only good oral hygiene, but cancer prevention?
That's so, from the standpoint of the carcinogenic effects of smoking and drinking, brushing your teeth doesn't really play a role here in terms of whether or not brushing your teeth would make you more at higher risk for oral cancers. But people who have poor oral hygiene can sometimes have underlying medical problems, or in fact, people who smoke tend to have more poor oral hygiene than somebody who does not smoke. And that essentially would either trigger the clinician to look into whether or not they're at higher risk and take any lesions a little bit more seriously that arise in the oral cavity and give us a lower threshold to biopsy them.
Okay. So we have a few questions from our audience. So, and hopefully I will pronounce this correctly, but how often does oral lichen planus lead to cancer, and what are the best ways to treat it?
Lichen planus, basically irritation of, like, do I have this right? Lichen planus?
Yes. It's
Okay.
just my mispronunciation.
In terms of percentage, I don't have the numbers on hand here, but lichen planus essentially is an inflammatory condition. And just like we talked about malfitted or misfitted denture wear, local inflammation can predispose areas of the oral cavity and the head and neck to developing cancerous lesions. It's something that usually is watched very, very carefully. And not just lichen planus, a lot of other inflammatory conditions, even rheumatologic conditions that can have manifestations in the oral cavity or the oropharynx, are usually watched very carefully over time. The main issue here is how long a lesion is present for. That usually alarms us to whether or not we need to biopsy this lesion to make sure it is not transforming into a malignant lesion. So if a lot of rheumatologic or inflammatory conditions tend to wax and wane over time, where you have an exacerbation, but then with proper treatment, these lesions disappear. These are not usually alarming for us. The ones that persist for a long period of time or grow or change in shape, these are the ones that usually are more concerning for us.
Okay. And again, just to clarify, what are the best ways to treat it?
Lichen planus?
Yes.
Or oral. So usually we get our rheumatologic or rheumatology colleagues involved in this, but topical steroids, and there's a lot of biologics now available to treat lichen planus. We usually in the field of head and neck surgery don't necessarily manage these chronic patients, but we usually see them from time to time when there is either to diagnose them in the very early stages, or when there is a lesion that is not responding appropriately to therapy. Then we are called to intervene to make sure this is not a malignant lesion.
Okay, thank you. So the next question kind of refers back to the last question about good oral hygiene and the role of brushing. This question says, what about flossing? So I guess what role does flossing play in good oral hygiene and in oral cancer prevention?
Not really much of a role in terms of oral cancer prevention, but definitely in terms of avoiding any chronic irritation to the gum region in between the teeth, removing plaque, and lessening any chronic irritation that can happen to the same site, for example, in between two tightly fitted teeth, for example. These are things that reduce irritation of the gums and can supposedly lessen any potential risk for oral cavity cancer, but it's not a cause and effect relationship.
Okay, thank you. So this question from our audience member is asking, does soda pose a risk for oral cancer?
Not that we know about.
Okay.
Other health issues, but not oral cavity cancers.
Okay. Is there any other foods or drinks aside from alcohol and tobacco consumption that would pose a risk for oral cancer?
So yes, there's other forms of tobacco or smoking that is implicated in oral or lip cancers. For example, pipe smoking is implicated in oral cavity cancers. A common practice in Southeast Asia or India, chewing on betel nut is very highly carcinogenic, and it is very much implicated in oral cavity cancer. Really, cigarette consumption and alcohol consumption in the States are the two greatest risk factors. There's very other few factors that are worth mentioning because they really don't play much of a role. It's really mainly smoking and alcohol consumption.
Okay. Do you include within that smoking, do you consider vaping and the chewing tobacco in that bucket?
Chewing tobacco, absolutely. In fact, chewing tobacco probably carries a higher risk of specifically oral cavity cancer than just smoking because of the prolonged exposure to the tissue to the chewed tobacco. Sorry, I missed what was the other part of the question?
Chewing tobacco and vaping.
Vaping, yes. Vaping, the verdict is still out on this, but there's definitely a consensus that some of the metallic elements that are produced during the process of vaping and that the oral cavity mucosa is exposed to, such as nickel and I believe chromium, are considered carcinogenic. And I'm not sure if we have enough years to validate this cause and effect, but it's definitely something that's in the back of our heads in terms of, many years down the line, we'll probably see an increase in oral cavity cancers in the younger population versus when I mentioned earlier, the average age is 60 years old. We may be seeing a rise in oral cavity cancers in the future if vaping continues to be on the steady incline.
Okay, all right, thank you. So we have, oh, wow, we're getting some great questions in now. So if one constantly keeps biting the inside of their cheek, can that injury lead to a cancer in the inside of the cheek?
So leukoplakia is a very common type of oral cavity lesion. It's kind of a whitish lesion, which most people can find the surface on their tongue or on the inside of their cheeks. And that's very commonly seen in people who bite the side of the cheeks. Again, not, many people bite the side of their cheeks. I can't tell you that I've seen many people with buccal cancers relating to just biting their cheeks. But theoretically, the same way misfitted dentures can cause or increase your chance of a lesion at the area that's chronically irritated. Sure, we can theoretically talk about this, but again, not a very common finding in my clinical.
Okay. So are people who are prone to cold sores more at risk for oral cancer?
Not necessarily, because cold sores tend to develop in different sites. It's not common for somebody to have a cold sore over and over again at the same site. Anybody who develops a cold sore, again, back to the timing factor, for more than 3 weeks should have it looked into, should have it essentially biopsied. Okay.
So do you advise against using mouthwash with a 21%, I guess, alcohol as is the ingredient?
I'm not sure if the threshold is established. We just know that a higher alcohol content is a risk factor for developing oral cavity cancer. Off the top of my head, I don't recall what the percent of alcohol is in the commonly sold Listerine now or other mouthwash products over the counter, but 21 is not very far off from 25. I'll probably steer a little bit lower than that.
Oh, good to know. And this is just a general question. If there is like that risk of it having be 25% or higher that may cause oral cancer, why are these types of products allowed to be on market? Or shouldn't there be a warning label on it?
I think because it's a recently found issue here. It's recently noted, and that more of the manufacturers are now steering away from higher alcohol content in their over-the-counter mouthwash products.
Okay. So another question, is the risk of smoking marijuana the same as smoking cigarettes in the case of oral cancer?
There are definitely carcinogens in anything that you put on fire and inhale. Again, the correlation is not as well defined as with smoking cigarettes.
Okay. All right, I think that was all the questions. I'm just double checking. Any last questions for Dr. Abraham? Okay, well, if we don't have any other questions, I'd like to, thank you, Dr. Abraham, and this will conclude today's webinar. So the comments today by our medical expert are not a substitute for medical advice from your own physician. If you need a physician, please call our physician referral line at 1-888-724-7123. For more information about Robert Wood Johnson University Hospital Somerset, visit us at www.rwjbh.org/Somerset. On behalf of Robert Wood Johnson University Hospital Somerset, thank you all for joining us today and have a great afternoon. Take care.